Guys, just checking everything is up and running. Move that over there. I'm going to kick off today's live session talking about whether you should use a lumbar belt when you are recovering from a disc herniation. Now this came from a comment from one of the members in the group, and they were using a belt to progress on. They've made some really, really good progress on hip hinges and squats, and then we put a belt on, and it said I just used it for more support. And I wanted to touch on this specific comment, this belief that the belt is going to help you, knowing that most of you guys have a L4-5 and L5-S1 injury, so an injury to this bottom section of the lumbar spine. And I'm going to talk about a few bits and pieces, and then guys, if you've got questions, you can post them down in the comments. I've got the comments up on YouTube, I've got the comments here on TikTok as well, so hopefully this is going to be really helpful. But the first thing, I was just going to talk about a few little bits of data that I'd pulled in here. Point number one is that when you look at a lot of the research looking at and analyzing the effectiveness of belts, for example, and why we're using it, because we want to support the lower back so it doesn't round and bend forwards, right? That would be perhaps the rationale, increase intra-abdominal pressure and so that we don't round and bend forwards. Firstly, most of the research is not using any kind of imaging. They're not looking at the imaging of the spine. They're also not looking at the segmental angles. So, for example, when we are bending, a lot of these studies that look at the effect of the belt reducing stiffness or increasing stiffness and protecting your back, just look at the total bend. They don't look at where it's coming from because most of them are surface level imaging. Now the next thing, got a little conclusion here, pulled from looking at the research. Current research demonstrates, I'll just read it out to you, that wearing a lumbar belt alone does not significantly reduce flexion at L4-S1 segments during a squat. And I'm going to try and explain to you guys perhaps the reason why some of these things might be the case. And just so you guys know, this is pulled from a really cool research app, which is kind of like PubMed, but better, for those of you that know, and that's called Consensus. And it analyzes a number of different researches or pools of research, and then kind of gives you elements of conclusion. Then it lays out all of the different papers that have been referenced in this, the quality of those, and the consensus, literally, of the various papers. So that's something that was really interesting. The final one was, does the use of a lumbar, the question here was, does the use of a lumbar belt have any effect on lumbar flexion during a squat and deadlift? Which is why we were using it here, because there is this belief that the guys use the belts to support their back when they're doing these lifts. And so the conclusion again here, current research suggests that the lumbar belts do not meaningfully reduce lumbar flexion during a squat or deadlift exercise. And their primary benefits appear to be trunk stiffness and perceived stability, not in reducing lumbar flexion specifically. And so the main concern we have when we're talking about recovering from a herniated disc is putting the lumbar spine into a position of flexion, forward bending, and that putting significant strain on the lower sections of the lumbar spine, provoking that herniated disc at L5-S1. But I'm going to hypothesize a reason as to why this doesn't work. Now, number one, it seemed that if there was any benefit, and I'm going from memory here, but if there was any benefit, even though it wasn't significant, it was in the trained individual, the individual who knows. And this ties in really nicely to the seminar that I was on the other week with Sean McInroy, the Australian guy who's really, really strong. And he said, you earn the right to use a belt when you don't need it. And I think that's such an important thing. So basically, if you have a back injury, you don't have the right to use a belt because you haven't earned that right. You haven't earned that control. You haven't earned that stability. And so all you're doing is just this belief. I think it's just like, it's one of those beliefs that we have that we don't question why we have that belief. Why am I putting this belt on? Because it helps my back. Why? Why does it help my back? Who said it helped my back? Oh, well, people just do it, right? Because it's a support, and it's called a support, so it must support my back. And so perhaps it does support, right? Perhaps it does support the section. But I've talked about this before. When we use a support, a joint support, the mechanism around a joint support is that it spans the joint. So it's basically creating stiffness like the capsule of the capsular ligaments around that joint. So if we take, for example, the elbow or the knee joint, wearing knee sleeves when people do a squat, you feel it increases the stiffness of the knee to give you a little bit more protection as you go down, for example, right? I used that with my knee after I'd had the meniscus injury, okay? But it's around the knee joint, right? Most of you guys have L5-S1 and L4-5 injuries to the lumbar spine. So assuming you are a skeleton, which most of us are not, the lowest level you can get the bottom part of the belt to is going to be about the L4 vertebral body. which means it's not at the L5, it's not spanning the L4, L5 joint, and it's certainly not spanning the L5-S1 joint. And so it's only serving to stabilize, if it is stabilizing at all, this section, if it is. And it's not clear that it is at all in the flexion component. Yeah, sure, it's creating more pressure, but that pressure without actual stability is well, it's just pressure without actual stability. And so what's worse is that if flexion is leaking through the lumbar spine, now if this area is actually more rigid, it's only going to go more through these lower sections. So I'd argue, not only does it give you a false sense of security, or not only does it not work, but it also gives you this false sense of security if you are someone with a back, right? Let alone if you're someone with a bad back, a back that needs support, a back that actually you need to build your own support and awareness. So I thought it was a great opportunity to have a chat about that on the live. I hope it's helpful for you guys. If you have any questions about the supports specifically, and whether you're watching now or watching after the fact, you can post them down in the comments and we'll go through those. I can see there's a bunch of comments coming in on TikTok, so I'll come through these and comment to these now. What else have we got here? Let me try and go back to the start where the first comments came through. Okay, where are we? And guys, bear with me because there's a lot of stuff on here. It'd be great if you could filter this for comments only. Any tips when it comes to having to dig at work when you're suffering with an L5-S1 disc bulge? James, you've got to make sure you're doing your rehab work. Make sure you're bending with your knees. I had to do a DIY project maybe a year ago now where I was digging out part of the driveway. And the worst thing you can do is stand up here, for example, and be digging down here, right? There's no real ideal way. You want to try and use your body as much as possible. Use your hips as much as possible. Keep your spine as neutral as much as possible. I'd suggest if you can have a chat with the other guys that are on site, if they can do some of that and you can do some of the stuff that's in a more neutral position, but it's not ideal. It's like saying, how do I go and run with a broken leg? Well, the answer is you actually can't, so you don't. And this is probably one of the biggest challenges with back pain. When you have things that you shouldn't be doing, you do them anyway. Whereas if it was a broken leg, James, you wouldn't be on site. You wouldn't be picking stuff up. And that's the biggest reality until you are ready to get back into that stuff because you've made significant progress with rehabilitation. And so, I'm a driver. What happens when you broke your right leg? You can't drive. Sorry, you can't drive for that period until the boot comes off. Legally, you can't drive. And so you're forced to actually get better. But with the back, we can game the system. We can force it. We can gerrymander our way through and do stuff anyway and allow ourselves to get worse. So it is very difficult. And I'm very, very empathetic because if you've got to work, you've got to work. But, you've got to step up the care of self-work to offset some of that bad stuff that we're doing every single day. Lillian has said, where have you been? I had a spinal discectomy because of the trapped nerve. We've been here. Lillian, but I think that's just a phrase. If you've had a microdiscectomy, send us a DM because we have a podcast episode on post-spinal surgery. But the long and short of it is check out the link in the profile page up here because there's the rehab that will be very helpful. Watch the video on that page, Lillian, and it should be fairly self-explanatory from there. The most important thing we do, guys, remember, when you have any discectomy surgeries, there are two problems that result in you having the discectomy. There is the problem of the herniation, which is the secondary problem, which is that this herniation is pressing on the nerve, which is why you've had the discectomy, which is what's been happened. It's been removed. But the primary problem is the fact that this annulus was like this, intact. And then it became like this, torn. And then it broke through significantly, more torn. The discectomy does precisely nothing to heal that damage that is here. Nothing at all. And so your rehabilitation is important. It's very important, and it's often, unfortunately, or rather it's not often, it's too often not discussed. Fine has said, I just want to go back to cleaning my, washing my clothes without fearing the worst when wringing them out. Building back up strength and stability is what's going to get you there. A lot of people have a lot of fear when they've got a lower back injury. You fear that the next thing's going to flare you up. The one thing that you can do to counteract that fear is have a database of evidence. If you know for a fact that you could only do a squat or a hip hinge with 3 kilos, and now you can do 13, and now you can do 30, you know that you are stronger. You know that you are healthier. You know that you're more resilient because you have evidence. So often we get comments in the comment section. People are saying, how do I know I'm healed? How do I know when I'm healed? How do I know when this disc is healed? It's like, you don't really. It's healing. You don't know how far it's healed unless you are doing things that demonstrate just how healed it is. And so your rehab is that process. The rehab is the test, it's the exercise, it's the reevaluation tool, it's the progress tool that you use. And so that's what gives you that certainty as to how strong you are and whether you can go back to these things without silly little risks or without feeling like they are silly little risks that are going to set you back again. Butterfly said, I had an MRI, revealed 2 herniated discs, but why do I have neck pain? I can't sit for long. You don't. Unfortunately, so many of the factors that are leading to people having these lower back issues, which is why they're so common, also affect the neck. We spend hours every day, probably like right now, like those of you guys on TikTok, right now, how many of you are sat like this on your phone watching? And how many of you are sat like this? Probably none of you. You're all sat like that, right? That's why we've got neck issues as well. Patrick has said, gone for a long walk. Is going for a long walk good for lower back pain to get things moving, or does it just pinch more? People misunderstand the role of walking. Firstly, walking should be aggravation-free, or rather, we should only walk for aggravation-free durations, meaning that if your symptoms start to worsen after walking for 10 steps, don't push it and keep going. If the symptoms start to worsen after walking for 5 minutes, don't push it, keep going. If the symptoms start to worsen after 20 minutes, half an hour, don't push it, stick to aggravation-free. The role of walking is that walking creates a little bit of movement and it helps get rid of some of the inflammation in this area in the lower back around these nerves. So walking is good from that point of view, in a good position, etc., without aggravating your back. Because if you're aggravating your back, walking is a load tolerance issue. So there is a point often that the load starts to become problematic. And so you stick to aggravation-free durations because it is helping getting things moving, alongside other relief-based strategies, such as the contrast bathing, such as the towel decompression, the bed decompression, and those kind of things that we talk about in the program. But it is not rehab. So you don't just walk. If walking feels good, you don't just walk for 4 hours a day. You do your rehab because, and we typically say, like once you're getting up to 20 minutes of walking, doing that a couple of times a day is fine if you've got the time, but it should not be taking away from your rehab. You must be doing your strengthening and rehabilitation work. That is what is getting you better, not your walking. There we go. What else have we got here? If you want to give your exercises to if you want to give your number 1 exercise to fix L5-S1, what would it be? Someone always comes and asks this question. So I think that the squat is going to be the best exercise, and I will explain why. And in close second, so this is the best exercise to fix your L5-S1 injury. And that could be disc. What we would be better saying would be segmental injury. Why the squat? Number 1, the squat is a movement that every single one of you watching right now, no matter how bad you are, no matter whether you've had just had surgery, like one of the comments earlier on, or whether you haven't, the squat is an exercise that all of you can do, right? And the biggest mistake people make is they say, well, I can't do a squat because that's a scary exercise that you do in a gym with weights. It's like, no, a squat you can do holding onto your partner's hands like that. People mistake in the fact that you either have to do a squat with lots of weight or nothing, and that's not true. The squat, you can hold onto the door frame and go like this. That is a squat, right? Understand that is a squat. That might be where your squat starts. So the squat is accessible to absolutely everyone. When performed correctly, you are learning how to stabilize the midsection, keeping your spine still and just bending from the hips. And there's a little bit of a hip hinge in there as well. So you're building core control, spinal control in the squat. And because everyone is already doing it, it is an exercise that has spillover benefit, meaning that you're not just learning the squat for your rehab, you're learning your squat because it means that you get in and out of the many chairs and beds and sofas and cars, etc., with more skill and in a more safe way rather than constantly aggravating things. So it has benefits outside of the workout. The squat can then be scaled to all levels for the long term, meaning that you're using weights to start to not only build strength in the muscles around that area, but also strengthen up the spine. And when you've got a very good squat, as you start to scale the load, you're able to safely apply load to the spine so that the spine itself can get stronger. And Raphael said, and why do I get more sciatic tension when I'm doing the slump test? When I kick off my non-affected leg, it's because you're putting flexion through the lumbar spine. It really varies. It might be that your non-affected leg has a little bit more stiffness in the hamstrings, and therefore it's pulling the lumbar spine into flexion and exacerbating those symptoms. But one of the most important things, Raphael, to do is not to get too caught up in the variation of symptoms. You will see from a lot of the comments that we get on here on TikTok, and I'll go back to the TikTok questions in a second, a lot of the people have all the same sort of segmental issues, and they all have different types of symptoms. With the absence of emergency symptoms, which we've talked about many times before, so I won't go into it again. In the absence of emergency type symptoms called equina type symptoms, focus on the rehab and getting better rather than nuanced differences of symptoms from one side to the other, from this to the other. Those are interesting, observe them, sure, but focus on the rehab side of things. What have we got here? Butterfly says, oh no, we've done that one. I had 4 operations on my back. Goodness me, Chris. Hopefully you're doing better now. Lillian said, after surgery, I now have nerve damage in my left leg, numbness and migraines. I'm not sure about the migraines, Lillian, but it isn't uncommon for people to have a little bit of nerve damage after the surgery. We get people, you know, the way it's sometimes phrased to the patient, because we've had patients that have had microdiscectomies and this has happened to them. It's like we kind of bruised the nerve a little bit while we were doing the work, and you've got a little bit of numbness, tingling, altered sensation in an area, maybe the big toe or something like that. And steadily, the idea is that will heal, but nerves heal very, very slowly. They heal very slowly. And so it's just something to observe as you're progressing with your rehabilitation. What else have we got? How do you heal a bulging disc? Oh, so that is a very good question. You don't heal the bulging disc. You do, no, sorry. I don't heal a bulging disc. You heal your own bulging disc. And what I mean by that is, how do I heal my little finger, right? How do I heal my little finger? I've got a little cut there, right? Someone didn't cut their nails before jiu-jitsu the other day, right? And I got caught, it was bleeding. How do I heal that? Exactly the same way as you heal a herniated disc, by doing nothing. And what I mean by that is, it's gonna heal on its own. The reason that most of you guys are struggling is because you're getting in the way of that healing process. If I keep knocking that finger on stuff, on my clothes, etc., then I'm keep on picking the scab and it keeps hurting. But if I stop doing that, get out of the way of the disc that's trying to heal, stop making it worse, then it will go through its healing process. And then if I support that with appropriate rehab and strengthen this area up, it will go through the strengthening process, the second part of healing, if you will. And so understand, no one heals your discs but you, and you don't consciously heal your discs. They are trying to heal every day. And the difference between the person that's struggling for a longer period of time and the person that gets better in a very short time frame is the degree to which the one individual is interfering with that healing process. And most of the time, it's a case of you don't know what you don't know. You don't know that you're doing it because you haven't been taught about it, because it's not your area of expertise. And I'm sure there are many things that we all do, myself included, that are not advisable for a variety of different things, right? Because we just don't know. And that's why education is so important with the back, because unlike many other injuries where it can be taken out of the equation, you could put it in a cast, in a sling, in a boot, like we mentioned earlier, and stop you messing it up. We can't do that with the back. And so education is so important when we talk about recovering from lower back injuries. What other questions have we got here? Dishanka said, I religiously followed your lower back video 2 years ago and my back pain was gone. That's awesome. Thanks for sharing. Agent 47 has said, I have sacralization and it's giving me very bad pain. Any advice? Yes, sacralization doesn't give people pain. And I don't mean to say that, that sounded really direct. Sacralization is something that you've had your whole life. Sacralization is essentially a congenital abnormality. It means that the L5 is typically connected to the S1. So it means you've got altered function, but the sacralization itself is not what is causing the problem. It is that you have sacralization, which was most likely found out after you'd injured your back, and then we're focusing in on the wrong thing, right? The sacralization has its disadvantages. We always say, to the degree you have an anatomical variation, such as sacralization, such as Bertolotti syndrome, such as lumbaralization, which is the opposite thing. One of the sacral vertebrae looks more like a lumbar vertebra. To the degree you have these, to the degree you've had a surgery, to the degree you've had a fixation via fusion, you have different anatomy. You need to focus on the things that we talk about more. You need to focus on stabilizing the spine. You need to focus on building load tolerance and control, skill around movements like the squat, for example. And then once you've built good load tolerance, it is implicit that building load tolerance will get you strong muscles. You then improve the mobility of your hips specifically, because if the hips are a little bit more mobile and strong, I stress strong first, then they can offset the requirement for the lumbar spine to be involved. And if we've got sacralization, we've got one less normal joint in the lower back, maybe two, maybe three, depending on exactly what kind of variation we've got. And therefore, we've got less joints to partake in the same amount of lumbar motion. And so having more mobile hips offsets some of that disadvantage. What other comments have we got here? Why do I get pain just above the tailbone when I stand or go for a long walk? It is very common that injuries to the L5-S1 section of your lumbar spine will cause a referral pain down in this area here. So people will frequently say, I've got back pain and it's going down here, knowing that the lumbar spine is here, but the pain is here. Very, very common. You're walking, you might be, if you're going for a long walk, it might be up and down. Up and down, that's going to put strain on the lumbar spine, the lower lumbar spine. We create a bit of irritation, a bit of inflammation, and then we get the symptoms that we experience. Going back through some of these TikTok comments, what else have we got here? Have you ever seen thoracic outlet syndrome in the first rib compression called cervical herniated disc? No, I would suggest I'd be looking more at the cervical herniated disc being the primary issue. Found out that I have herniated and bulging L5-S1. The pain is only in the back, no sciatica. That's awesome, Brendan. Just make sure you focus on the rehab stuff soon. Check out the link up here for more guidance on that. Someone's still waiting for a diagnosis, butterfly. I have severe heel pain with my S1 disc bulge. I'm just going to read a couple of these out, and then I'm going to add a point here because someone commented, Raphael's comment about the L5-S1. You guys are asking about how the surgery went. Hope it went okay. I've heard horror stories. I'm back to doing my job full-time 6 months after herniated disc. Thoughts? I'm back to doing a hard labor job. It depends, Kobe. It depends if you've actually done the rehab, right? If you've done the rehab and you've built up strength and stability, then you can compare what you're doing in terms of your rehabilitation exercise. Understand the long-term goal of your rehab is that your rehab turns into strength training. Really, they're the same. You just call them different things because people freak out if you just herniated a disc and say, go and do strength training. Fundamentally, that's what you're doing, right? You are doing strength training. You're just calling it something slightly different. The idea for your rehab is that long-term, your workouts are up here in terms of strain on the body and daily life is relatively down here. At the moment, your ability to perform a workout when you're struggling with a herniated disc is here and daily life strain is up here. So it's no wonder you're struggling from flare-ups one day to the next, 1 minute to the next, 1 hour to the next, right? Because you are not competent. You don't have capacity to protect that lower back. And so our rehab should shift around this way. Now, if we have to have a hard day on site, for example, thinking of the hard labor job, and it pushes up to here, no problem. We're still way more capable of doing things because we've built resilience into the human body. That's the idea. I found out I have a herniation hip. We've done that one. I had L5-S1 injury 4 weeks ago. When is it safe to do strengthening and conditioning? Daniel, you should be focusing on rehabilitation immediately, but you find what level is right for you. So as we discussed a little bit earlier on, right, we're starting the squat. Understand, to what I said a moment ago about strength training is rehab. If you're going about, and too many people make this mistake, I hope those of you that are watching use this as a warning for about 3 to 4 months' time when you go back into the gym at the start of the year, or if you know people that do. They go into the gym to get back in shape, or whatever it may be, at the start of the year, and they injure themselves because they don't go about training in a sensible and humble manner. First of all, you need to establish that you have appropriate technique. Then you need to experiment with that technique, pressure tested in the exercise. So using maybe the squat rack, and using maybe some dumbbells to hold on to. Maybe you're doing a squat, for example, or you're doing a hip hinge, right? To check that that technique doesn't fall apart. And then you need to find the appropriate level of load that you can still do competently without aggravating any symptoms, so that you can effectively challenge the muscles, and then you do that over a period of time. That is strength training. That is also rehabilitation. So the task is, you need to find where that point is. That's something that we talk about and we walk you guys through in the phases of the program, phase 1, 2, and 3 specifically, to get you to that point. Too many people, like at the start of the year, will just go in and say, oh, I want to get back in shape. So they'll go and do some like fitness classes and completely skip over step 1 to 3, kill themselves for 2 weeks. And then by the time the middle of January rolls around, everybody's injured and they're like, oh man, I'm injured again. And then there goes the weight loss strategy for 2026. It happens every single year. We have to focus on technique first, and also acknowledged, back to Daniel's question about when we should be starting to do this kind of stuff, day 1, because Daniel, look at everything you're doing every single day already, right? You're already getting dressed in the morning. You're already going to the bathroom. You're already getting out of bed. You might still be going to work. You might have a kid at home, playing with them on the floor. You might have a bunch of different things that you're already doing every day that are significantly more strenuous and more provocative and more problematic than careful, controlled rehabilitative exercises, such as those that we talk about in the core 5, dead bug, marching bridge, squat, hip hinge, step up, the additional new single leg hip hinge. Learning those safely can be scaled to any level of ability, and then you start from there. And you need to know that, because quite honestly, if you can't squat to here, beyond here, without losing form and rounding your lower back and getting pain, how are you getting off the toilet seat, right? You're gonna still do that. And so you've got no awareness. And like we see this with patients in the clinic. They come in, they go, oh, my back's so sore. Every time I get out of the chair, it hurts. Oh gosh, so painful, right? And then you show them, you say, well, why are you getting out like that? Get your feet underneath you, engage yourself, hold yourself a little bit more, and then just go straight up. And they go, oh, you fixed my back pain. It's like, no, I didn't. I just taught you how to stop making it worse. Now, that's the process of learning how to move correctly, for example, right? And so if you learn those things, immediately you have benefits. Immediately. What have we got? Lillian said, I'm not a professional, but physical therapy didn't help, so I had to strengthen it. Physical therapy, I think, is like, saying I did physical therapy is like saying I did exercise. It means everything and nothing at the same time, unfortunately. Bear in mind, of the thousands and thousands of patients and members that have come to see us either in the clinics, that are members of the program, that I've seen in clinics before we'd ever had our own clinic, everybody's done exercises before they joined the program, right? Everyone's done rehab before they joined the program or came to the clinic. Everybody's done that, right? And the funny thing about the program specifically is everybody's done exercises before joining the program. Many of them have even done the exercises they do in the program before joining the program. But it's how you do it, how you approach it. It's also how you approach it from one session to the next, how you learn it, how you approach progressing it over time. And so, for example, if you've been to physical therapy and you go through an exercise and then you go home, you have nothing to refer back to, and you see them again in a couple of weeks or a couple of days or a couple of, whatever, next week, that's not good because you have no mechanism. How many times do you remember what has actually been said in a conversation with a friend in the detail, the intricate detail necessary to execute and recount that conversation in detail an hour later? You walk out of the clinic and you've forgotten 60% of what's been said immediately. And that's just normal, right? It's not like it's a criticism of anyone. It's just normal. And so if you don't have stuff to go home with that's going to help you make sure you're doing it right, then you're going to struggle. And if you've been given a sheet of paper as part of your physiotherapy, I saw we had a comment on TikTok earlier today, and they were saying, yeah, I waited ages for a face-to-face appointment at the physio, and then they gave me a sheet of paper and sent me home. It's like, yeah, because that's what physio often is. That's what physical therapy often is. Maybe they went through a few of them and then sent you home with a sheet of paper. That is not rehabilitation. That is not a program of rehabilitation. And that is useless, quite frankly. And so, it's no wonder we don't get better with physical exercise when that's the physical exercise or guidance that we've been given. What other comments have we got? We've got a lot of comments. You guys have been saving these up over the weekend, have you? I'm back to doing hard labor job. You can't necessarily stop sciatica. The only thing that helped was strengthening. Yes, strengthening is the route forwards. Rebuilding strength and resilience is the pathway to you guys getting better. What else have we got? Neither told me to go home, stretch twice a day, and made me more stiff. Yeah, guys, when you stretching is really has very limited value. Please bear in mind, we include stretching in the program, right? We tell you guys to do some stretching when we talk about the core relief work, right? Keeping those hamstrings flexible. Most people cannot stretch effectively, and there are two reasons for this. Number one, they don't know. So when they do a hamstring stretch, they go like this, straight over. Yeah, you're getting a bit of hamstring maybe, but you're getting a ton of back. And the back component isn't stretching the hamstring, so it's a waste of time, and it's detrimental to the lower back. And number two is that most people struggle to perform a hip hinge. And so if you can't perform a hip hinge, that demonstrates that you don't have the ability to split lumbar movement from hip movement, and therefore you struggle to effectively stretch the hips without aggravating the lower back. So while you might get some momentary improvements in flexibility, you undermine it by the fact that you can't really control your back, and then you flare your back up 15 minutes later, and everything's tight and stiff and sore again. It happens over and over again to people. Other comments that we've got in here, L5-S1 disc herniation and sciatica reducing, feeling pain in my lower back, is it normal? One of the things that you guys do get with sciatica specifically, some of you will notice from the comments, oh, I've got back pain, but I haven't got sciatica yet, or I have back pain, then I got sciatica, and then like in this case, for example, now it's going back towards the back. I have no back pain, but I only have sciatica. The process of centralisation is by which the symptoms that are in the leg down here, wherever it may be, normally the back of the leg, maybe the big toe, okay, back of the thigh, maybe a bit on the side a little bit. Those symptoms start to recede back up, and then we might have back and buttock pain, and then the back pain goes. That is the centralisation process. What often happens for people with back issues or sciatica is that they have had back pain before. They've maybe had recurrent or long-standing back pain, and then it starts to go down here, and then it starts to go down here, and then they might get to a point where they have no back discomfort at all, but they just have the sciatica down the leg. And so that's things getting worse, and then when things go back towards the spine, generally speaking, that is a cue that is actually getting better, which is a good sign. The doctor said I have nerve damage to my lumbar
sack and said physio won't help, but in constant pain. I'm not too sure what we're saying there, unfortunately. I did physical therapy and pain management for 1 year. It didn't work for me. Again, Miss Perry, I think it was. Always what we were doing specifically is the important thing. Alice has said, a pelvic tuck's only good for an L5 disc fusion and compression. No, they are not. Pelvic tucks are flexing the lumbar spine. Pelvic tucks are frequently taught in Pilates classes, in yoga classes, etc., and even by your physios, to flatten the lumbar spine into the ground. Okay? You do not need to learn to do pelvic tucks, okay? Flattening that lower back instead of supporting the natural lordosis. That is how it should be, okay? That's not arched, that is a neutral position. Arched is even more backwards, okay? Pelvic tucks are not helpful. They are frequently taught, if we move outside of the back injury scenario, they are taught because by the main error that we make, for example, if we were doing a leg raise, or let's take a dead bug, for example. When we're doing a dead bug and many other core exercises, the main mistake that people make is as the leg goes out, they arch their back. And that can sometimes, often, nearly always, create a bit of jarring in the lower lumbar spine because you're banging the facet joints together. And so if we do a pelvic tuck, or worse still, put our hands underneath our bum, we can do this all day and it's super, super easy because we're gaming the system. Rather than using our intellect and doing an easier version that we can do, we're just creating we're creating more support so we can continue to do that harder variation. A much smarter strategy is to focus on the neutral, because what happens is, we even had a question once, I always remember it. They said, how do I engage my core if I don't do a pelvic tuck then? And I said, that's the problem. Your core should not be at the mercy of whether or not you do a pelvic tuck. What's also worth looking at is the alignment. Alignment is important. I'm talking about gross alignment, right? Your hips should be over your, your head should be over your shoulders, your rib cage should be over your pelvis, and your pelvis should be over the ground, right? And so when we look at x-rays or images of the spine, what that means is that the center of the lumbar curve is where your center of mass is going to run through. And that's going to run through here, and then it runs straight through the hips. You can see that the hips are underneath the center of the lumbar spine. When we do a pelvic tuck, we do that. Now you can see the hips are forward of the lumbar spine, okay? It's moved you off balance. If you stand up and do a pelvic tuck, like so, and then try and straighten your legs up, you're flattening the curve. You're also having to engage all of these muscles, and you're super, super tight. It's not how you're supposed to stand. You're supposed to stand in a neutral position. So what you're learning then there, Alice, when you're doing those pelvic tucks, unfortunately, is the only way you can engage your core is with a pelvic tuck. So when you're standing, you do a pelvic tuck to engage the core, making your back more vulnerable, and you don't have any ability to just turn it on without moving. You should be able to turn off, turn on, turn off, turn on, turn off, turn on. Contract the core, turn it off. Contract the core, turn it off. Contract the core, turn it off, right? You can't do that without a pelvic tuck, because if you've only learned how to pelvic tuck and tie it to your core, it's incorrect. So hopefully that makes a bit of sense. You're learning something. The reason we're doing core exercises on the floor, like the dead bug and the marching bridge, is so we are learning a skill that transfers when we're upright. If we're doing a skill that doesn't transfer to being upright, that's a waste of time. It's quite frankly completely pointless. What else have we got here? Thoughts on McGill Big 3 for back pain? I think that the McGill Big 3 are, they're missing load. They're missing the load tolerance. And I think I've seen too many, for example, the curl down, right? The curl down, I've seen McGill teach it. So these are the two main issues that I have just with that one exercise in particular. I think the side planks, just holding side planks for time, I don't think is ideal because it's very difficult. I don't think holding exercises for time is a good scalable strategy. I think reps and sets makes more sense. It's easier to control good form in those scenarios as opposed to time and levels of discomfort. It's very, very subjective. And for me anyway, and communicating it to others, you need to have that degree of as much objectivity as is possible, right? And so sets and reps are better. With the curl down, 2 errors. Number one, when McGill teaches it specifically, and he is a very prominent figure in the space. So, and a lot of our stuff really does align reasonably closely with what he talks about, but some criticisms. He talks about, I think it's called the curl down, I think is what he calls it, putting the arm underneath the back, right? To preserve the lordosis, agree. But why the arm? It just shows, for someone who's very, very detailed, in my opinion, it shows a lack of detail. Look at my arm, higher, lower. firstly, I might not have the shoulder flexibility. Higher, lower. So now what I'm going to do when I put my arm behind my back to do that valid test, I'm going to be able to be arguably tracing a bit of twisting through my lumbar spine. And a lot of people with really bad lower back pain are quite sensitive. So that makes no sense. Plus, it's like, why not think outside the box like we do? This is one of the reasons we recommend the towel. So one of the tools that we give people when they're struggling with floor-based ab exercises, core exercises, is using a smaller rolled up towel. Because the rolled up towel is even the whole way across. So it provides support for the lordosis, filling the gap, the void underneath our lower back. And obviously we wouldn't roll it the same way we do when we do a full lordosis support, like the proper towel stretch. So normally when we do this as a stretching exercise, a relief exercise, we place this underneath the lower back to support the lordosis and get a bit of decompression. When we're doing it as part of an exercise like a dead bug, which would be very similar to the curl down, we'd only roll it, say, like so. And that will be variable for each individual based on how much fat and muscle you've got in that area, how much buttocks development, etc. So why not use that instead of using your arm, which to me, you know, we're so precise about everything else. Why is that looks a bit sloppy, in my opinion. And yeah, so that's that. Secondly, is I've seen others teaching the McGill curl down, calling it the McGill curl down, and talking about flattening the back into the ground, doing a pelvic tuck essentially. And it's like there's that miscommunication. The students, if you will, are not communicating it in the way in which he talked about it. He talked very specifically on videos about this particular exercise, about maintaining the lordosis, supporting lordosis, whereas others who are talking about the McGill curl down are talking about flattening the back to the ground. So something to think about there. Some comment there. Dish Anchor said, "Why are you not reading my comment?" Because I don't know what to say to it. I don't know what to say. Pelvic floor dysfunction. Cool. I don't have anything else to say. I don't mean that in a mean way. I think it's because pelvic floor dysfunction. I don't know what is because pelvic floor dysfunction. But anyway, Samuel, I have never had sciatica, sharp nerve pain, and I'm wondering how to tell the difference between DOMS in my lower back flare-up 2 to 3 days after going up in weight. Any advice? Generally speaking, you're going to have limitation in your hamstring stretching. So the nice thing is, if you're regularly doing your core relief work, for example, Samuel, if you're in the program, I'm not sure if you are, I definitely would also post in the video, post in the members area, a video of your squats or hip hinges in particular. It's most likely the hip hinges that are going to trigger this kind of thing. If you've been routinely doing your core relief work, you'd have an idea of the actual flexibility of your hamstrings, and then you go and do that on a day you've got DOMS, you're like, boom, oh gosh, that's stiff, that's tight. You might get the massage gun on there, and you're like, oh gosh, that's sensitive, you know? That would generally be a cue. So something to think about. The difficulty is that when we have the DOMS and the stiffness in the hamstrings, we need to manage it quite well after a workout, because this is necessary, right? It's necessary to go through this process, but we have to be forewarned of it. And we talk about that in the educational and strategy material in phases 3 and phases 4, because it's going to happen to everybody. You need to know to manage it well, because if we work out hard and then we've got stiffness in the hamstrings, although that's not a direct problem, it's a necessary consequence, that's going to start to limit hip mobility, and that can have an aggravating effect on the lower back. So they can be related, Samuel. Something to dig into more, but make sure you're doing your core relief work and being quite diligent on that front. A little bit of massage gun work can help as well, and obviously doing contrast bathing type stuff to the lower back specifically, and get into the members group if you're in the membership, and just give us an update on your technique on particularly the hip hinges, because I would assume that's where this has been coming from. What else have we got here? Can you show us typical errors when doing the hip hinge? Yeah, there's kind of 2 main errors with the hip hinge. The first one is that we are kind of, I use this like you're diving in, right? So people are bending forwards, right? You can see that. The movement is very much my torso going forwards, okay? That is just a forward bend, and a lot of people do that. The second one is as they go around like that, they might be doing the, let's pull that shirt up so you can see better. They might be doing the hip hinge a little bit, but then they kind of round the lower back at the end. That's the 2 main errors. There's kind of an additional error, which is the same sort of thing, and that is that as they go forwards, they keep the lower spine good, but then they buckle forwards from the top part, trying to move too far. And obviously then there's a squat hinge, which is kind of like that kind of thing, which isn't really a hip hinge and is kind of a squat. So those are the kind of the big errors that people make on the hip hinge specifically. Leanne has said, if I use a massage gun on my calves, and it's sore, is that a place I need to massage more? Generally speaking, Leanne, I probably wouldn't like disproportionately do that area, but I would observe it. Maybe you've done a long walk over the weekend or something like that, or maybe you've been working particularly hard on those step-ups or other single leg exercises in the program, and the calves are feeling it a little bit because they're having to do all that stabilization. So it's reasonable to suggest that it's kind of like a bit of a DOMSy sensitivity. But I will say for me, there's two areas that have always been really sensitive for me. One of the areas has been this bit here, and then the other has been the adductors. Like, irrespective of any injury or anything like that, they've always just been super sensitive. And as I use the gun more frequently, not just hammer them for an hour and a half, right? They become more and more tolerable to the massage gun. But just be gentle. Remember, you're not trying to tenderize a steak here. We're just trying to improve the circulation to that area, get a bit of exchange of waste products. So just don't be too vigorous with it, if that makes sense. What else have we got here? Guys, I want to keep going for, where are we now? 40 minutes. We've got about 20 minutes left. I'll keep it going. Any other questions, guys? If you're on YouTube, you can post them in the comment section. If you're on TikTok, just keep them rolling in. And of course, I did discuss briefly at the start of the live today about belts. So hopefully that's helpful. And if there's any other questions on that, you guys can throw them in the comments as well. What have we got? And guys, if you need more help, those of you that have been struggling with your back pain with your sciatica, I'll paste it in the YouTube chat in case you haven't already seen it. Check out the link there. Those of you on TikTok, link in the profile page. If you want to learn more about the program, the full Back in Shape program membership, that gives you the structure and the support that you need to actually get better with your back pain. The full program, all the support and all that kind of stuff, it'll be really helpful for you. What else have we got here? Calvin Scott has said, is having a PE of tuck when standing up bad for you? I was advised to do this by, I'm assuming me having a pelvic tuck when standing up. Yes, some pelvic, yeah. Unfortunately, some trainers will instruct you to do pelvic tucks. It's incorrect. You should have a neutral spine when standing. You don't do pelvic tucks. You certainly don't do that when you're squatting. You should have a neutral spine. Yeah, it's just incorrect. It's flat out, it's incorrect. You're going to put more strain onto the posterior part of the disc. Especially if you've got an injured lumbar spine, you're going to really focus strain through that area. Most of the pelvic tuck will have an effect at L5-S1 and then to a lesser degree at L4-5, putting strain on those segments. Remember, right, these discs generally are going to be bulging backwards to a degree. And this is why we use neutral spine loading for you guys to get better when we talk about these things. Because neutral spine loading means that as I press down, I'm pressing down perpendicular to the vertebra, to the plane of the disc. So when I squash down here, the disc works by the non-compressible fluid in the middle trying to escape. And if I squash down equally, it's going to try and escape in all directions. If I squash down on the front, it's going to try and escape backwards. And now most of the pressure is going to go through the back half of the annular fibers, roughly speaking, right? It's not quite that simple, but it's not too far off, okay? If now I'm squashing to the front and I have a herniated disc, I now have a few less layers that are intact at this particular point. So now as I squash down to the front, it's going to try and escape through the path of least resistance, which is part on this side here of the example of the vertebra. So we're creating problems for ourselves. We do not need. That's why strengthening in the neutral is the best route. It's the most predictable route. When we start doing things like Jefferson curls, which no one's mentioned, thankfully, on this episode of the live session, we get into real dicey territory. Patrick has said, should you always use a rolled up towel in the dead bug? No. I think we use the rolled up towel for the dead bug as a strategy to fault find. So there are two things you can do. Number one, it might be that you just need to do an easier version of the exercise. But it will help you realize what you're doing wrong. So the reason we put the towel there is that the towel underneath the lower back, and it's only a small towel enough to fill the space, not like when we're doing towel decompression, is there to tell you, wrong spine, is there because when you injure a joint, when you injure a section of the body, you injure the ligaments, the ligamentous tissue. Inside those ligaments, you have proprioceptors. Those are joint receptors. They tell the body and the brain where everything is, right? And so it's very common for people that have a bad joint injury, ankle, knee, whatever it may be, back, to not be very good judges of whether movement is or is not going through that area. And that's partially why you guys keep messing your back up, right? Because you don't know what's going on down there. And that's why teaching a neutral spine is the first step in starting to appreciate at least where it is in space. And so when we're using the towel, the nice thing about the towel is you're not very good at feeling what's happening in your lower back. And so we use measures. This is one of the reasons why we prefer the dead bug to the bird dog. The bird dog is on all fours where you're moving your arms and legs. Because with the dead bug, and we don't use the arms in the dead bug, because we put our hands here. so we can feel our core, because some people aren't very good at feeling when the core is. As the leg goes out on the dead bug, if you don't engage the core properly, particularly between the belly button and the pubic bone, your tummy rises. If your hands are there, you can feel that and you can offset it and re-engage. If your hands are not there, you don't feel it. Unless you look at the video afterwards. You should be videoing yourself. Most of you aren't. You should be, right? And so the towel offers another layer of sensor, if you will. It's like having reversing sensors on your car or a camera. As you're doing the dead bug, if you have the towel here, you can feel if you accidentally do a pelvic tuck because it increases the pressure on your back. The whole back, not in the disc, but the whole back. And if as you're doing the dead bug and your leg goes out, your back arches, you feel your back come off the towel. That's why it's there. It's there to help get, thanks for the fan thing, it's there to help give you that extra layer of feedback. Because the reality is, if you've been struggling with back pain for a long period of time, you're not a very good judge of what's happening there. So there are little tricks that we can use to help you feel what's going on, combined with recording so you can see what's going on. It can really help you navigate and find the right difficulty for you. And then you move on from there. Just looking back through these comments, because I've seen a couple have come in. What is safer for a posterior lateral herniation, flexion or extension-based exercise? Macaulay, I think you've missed the general gist of what we've been talking about, maybe because you've just come in. Neutral is what you should be focusing on. Focus on neutral. Most people have, generally speaking, a posterolateral herniation. The reason for that is that you have so in the structure of the spine, you have a anterior longitudinal ligament that runs along the front here, very, very thick, and you have a posterior longitudinal ligament, a little bit less broad, but still thick, and it runs along the back here. The posterior longitudinal ligament of the spine acts as an extra reinforcing layer for the annulus. It's not here, it's here. So generally speaking, the path of least resistance is slightly off to the side because there's not a reinforcing ligament outside of the annulus here to create reinforcing support on the posterior part of the disc. So that's just one of the reasons why they tend to go off to the side. Most of you guys will have a left or right herniation. It might be broad-based, it might be going all the way across, but it is very, very common for them to go off to one side more than the other. It's just the way in which we're structured, the way in which we're built. Because if the ligament was going all the way across, then it would create problems. Not least of all, the fact there's big bony bits in the way here. So Coral Reef said, when I had my MRI, it told me I had a Schmall's node. Will the program work for this? The Schmall's node is generally speaking going to be an incidental finding, and that's where part of the disc kind of starts bulging up into the vertebral body. And it's a sign that we've had too much pressure going through the lumbar spine. I would check, Coral Reef, whether that Schmall's node is in the lumbar spine, because quite often they are in the thoracic spine. Something to bear in mind. So it might well not even be in the segment that they're talking about, or the segment that is injured. If it's in your lower back, it can be, but they are actually quite common in the thoracic spine, in the apex of the thoracic curve, because as we slouch, we squash down through the discs in the thoracic spine, so around about here is apex of the curve, and so as we're bending like that all the time, squashing down through here. But in short answer, yes, if you've got a lower back injury, then yes, the program will be helpful for you. Amy has said, I had a discectomy a week ago. Physio can't start with me until next week. Anything I can start to do? Yes, careful, controlled spine stability based work. For example, right, the dead bug, you will all have seen that, but the dead bug can start off, you probably wouldn't lie on the floor. You might lie on the bed instead, because getting on the floor is a problem for you, Amy, because you've only just had surgery. So getting on the floor kind of doesn't make sense. You might start with just learning to engage the core with a neutral spine, maybe with a little towel in the lower back to make sure that you don't do a pelvic tuck. And you might be able to do like a psoas engagement. And then you might be able to do actually I don't know what you can do, right? No one knows what you can do. The physio next week won't know what you can do until you do it. Learning how to squat, for example, because Amy, you're still probably going to the bathroom, right? So you're still getting on and off a chair. You're still getting out of bed in the morning. So learning all of these movements make them safer. They make them safer, but you need to learn them carefully. That's why we have a bunch of tutorial videos and stuff in the program. So I would check out the link up here and then have a look at the program and all of the stuff we do and all of the education there, and then compare that to the physio that you go and start next week. And I'm very confident that you will see a substantial difference. Well, brilliant, thank you. Feel great. Want to start ASAP? Yeah, you should do. It makes no sense whatsoever that we have a really, really detailed, focused surgery. We're going to do this surgery. We've got to be really careful. We've got to do everything properly and And then it's like, oh, in the window just after your surgery, you can just do whatever you want. for 6 weeks until you have physio, for 3 weeks until you have physio, right? It makes no sense. Now, it's not do whatever you want. The guidance is invariably different strains of do walking, don't sit for too much, don't lift anything, don't twist, and that's about it, right? The guidance is a broad brush, and then it's like, okay, so, but what about everything else that I have to do? Can I get dressed? Yeah, you can do that. Can I go in the car? Yeah, well, we've got to send you home. Can I get out of the car? Yeah, we're getting in the car. How do you get in the car without twisting? There's going to be some element of twisting, right? You need to learn how to limit that, and you know, there's very little often guidance post-surgery, which is poor, really, and really, I think, you know, you should finish your surgery. I would suggest in an ideal scenario, you should finish your surgery, and the day before you've been checked out, you should maybe do an evaluation with a physio to go through the kind of stuff that we talk about. It could be any sort of professional, it doesn't have to be a physio. To go through the kind of the fundamental exercises like those which we talk about. To say, okay, well, look, how do we do these? Can we do these? Because you're going to have already done a squat. That was to get out of the bed and go to the bathroom, right? You did that in the hospital. You got out of bed on your own. And if the doctor says you can't do a squat after the surgery, just sit on the hospital bed and stare at them and just blinking until they rethink the stupidity of what they've just said. Of course you can do a squat. You're going to have to get out of that hospital bed and they're going to send you home. So to say don't do squats is lazy advice. We need to have more robust advice after these scenarios. While you're lying in the hospital bed, they could give you an extended video for like 3 hours on all this kind of stuff. But, well, that might put you back to sleep again. What else have we got? Feeling great. We'll start ASAP. This is really informative. Thank you. Thank you. Amy has said been focusing on sitting to stand. Yeah, the thing is though, right, with sitting to stand, for Amy, a lot of people can't squat to the depth of a chair without rounding their lower back. And so that's a real issue, right? And so that's why I say the squat is often safer. And someone will say, oh, we'll do a sit to stand, that's easy. Yeah, but a sit to stand might be beyond your current level. The question is, can you do a sit to stand? Can you squat out of the chair like so? Some people can't. They end up rounding their back. They're doing this, right? Because they can only squat to here correctly. And there's a gap, right? So what happens under normal circumstances? One of two things. Either they round their back to sit down, or they just boom. And do you think that's good for the herniated disc? Possibly not. Possibly not. That's why we talk about this kind of stuff. Ella said, can I heal a diffuse disc bulge? I feel like I'm losing hope as I keep having flare-ups. Ella, your disc bulge is trying to heal every day. It's no different to anything else. Like I said earlier on the live, you might not have been here, my little finger, I got cut at jiu-jitsu. Someone was not cutting their nails and it was bleeding a lot. But overnight, it did this magical thing where it healed. Now, granted, your discs don't heal at that kind of rate. These ligaments heal very slowly. And the discs, compared to other ligamentous injuries, are under strain every single day, which is why education is so important. It's very, very normal for people to be having flare-ups every single day, or not every single day, but multiple, frequent flare-ups. It might be daily, it might be weekly, it might be every fortnight or so. Because if you're not doing proper rehab and learning how to control and protect that area, then there are so many little things that are just going to be tripping you up along the way. So you have to be, putting concerted effort and time and energy into learning how to control and protect that area of the lower back so that it can go through a healing process. And then you start to progress on with your rehab and build strength and resilience back into that lumbar spine through the exercises that we talk about. Check out the link. And those of you guys, if you're struggling, you don't need to lose hope. You don't need to lose hope. It's very normal for people to have flare-ups, even when they start doing rehab, because you're just learning the technique to start with. And for example, when you go and start trying to do the dead bug or the squat or the hip hinge or those kind of exercises that we talk about, it's very likely that you actually suck at these exercises. Now, for the process of carefully learning them might irritate you a little bit. And it's like, yeah, but so is walking the dog in the morning. So is getting dressed in the morning. And those things have no benefit to your recovery. So you have to learn those, but having support and structure can really, really help you. So check out the link up there in the profile page. Those of you guys on YouTube, if you're watching, if you're in a similar sort of circumstance, check out the link that's over there. backinshapeprogram.com/start and watch the video there. It explains a little bit more about the program and how we help you guys and the structure and everything, and get started, because you'll see it's like nothing else. Amy said the NHS physio has been given for 4 weeks. Yeah, so you're just left to wonder what to do for 4 weeks after having surgery, which just makes no sense. I have an L5-S1 herniated disc. Tips to reduce the pain down the leg while waiting for injections. We're missing the point here. This is a very common mistake, right? So start dealing with the rehab now. Right? If you're on TikTok, sending us a DM for the surgery podcast. And whenever I talk about surgery, just insert the word injection, because it's the same. Why are we waiting from a rehabilitation point of view until the injections? the injections do precisely nothing to change the injury in the lower back. So what we normally suggest to people is start doing the rehabilitation stuff we talk about. Forget about the pain down the leg, although I mean that in tongue in cheek, right? Because if we keep trying to treat pain, which is what the injection is doing, we're never dealing with the problem. And that's the biggest issue with back pain. You go and see someone for your back pain, you go and see someone for your sciatic pain, right? Whereas when we injure the knee, we go and see them for our medial collateral ligament strain or our cartilage damage or whatever it may be, meniscus strain. Most of the time when we're seeing a practitioner for other injuries, it's an actual injury. When we go and see them for our back, it's back pain and sciatica pain. So we keep on trying to chase the pain. Whereas we should be doing rehab now. And what you'll often find is if you start doing the right sort of rehab, the stuff that we talk about, focusing on a neutral spine, you will find that the symptoms start to abate anyway. You stop aggravating yourself as much anyway. And you get to the point where if we've got injections booked in for a fortnight, 2 weeks, 3 weeks, 4 weeks, 5 weeks, 6 weeks away, you get to the point where you're like, I don't know if I necessarily need to have these, because I'm starting to get control over the area. I'm starting to feel a lot more confident about my own ability to manage this situation. And maybe I don't need to undergo the unnecessary risk associated with an injection. That's not to say that injections are not helpful for people. They can help people and they can be leveraged. At the end of the day, they wouldn't be offered still if they didn't provide some value on a cost-benefit analysis. But we should be talking about rehab in the scenario leading up to the injections. And if you have an honest conversation with your surgeon, with your specialist, say, hey, John, I know we had the injections booked in, but I've started doing this rehab and I'm actually feeling like I'm a lot more in control of my levels of pain on a daily basis. I've made progress through the rehab. Understand, it's making progress through the process of rebuilding your back after a herniated disc or a back injury. That is what leads to the symptoms getting better, rather than some funny stretch that you can do in 2.5 minutes to get rid of your sciatic pain, right? It is progressing through the rehab that gets your back better, because that is what is helping the herniated disc. The injection does not do anything for the herniated disc. And arguably, if we're just relying on the injection for the herniated disc and not doing the others, which happens too much, really too much, then we're actually probably setting ourselves up for more trouble in the long run. Because if that injection does work and eliminate our pain, pain was probably the only thing that was stopping us, making it even worse. Something to think about. Not always the case, but often. Raphael said, do you recommend decompression exercises both the acute and chronic stage? We recommend the towel decompression and the bed decompression long term. Consider them back health stretches. Most of us spend too much time every day. We quoted this, I quote it till the end of time, well, unless I see something else is better. British Heart Foundation, unrelated to back pain, did a study, and it was talking about the UK population. Average person spends 9.5 hours a day sitting. You spend so much time sitting every day, and they're looking at heart health. The implications of that on your lower back is that when you sit, you put 40 to 90% more load through the lumbar spine than when you are standing. And therefore, if you're putting load through the back every day, do the decompression exercises, do the decompression stretches. They are back health stretches. You use your teeth maybe 2 or 3 times a day. Why are we not doing at least the same amount of time doing stuff for our back from a decompression point of view? It's worthwhile doing, it's helpful. And I think, the motivation to do that gets less and less the better and better we're feeling, but I think it's still worthwhile doing. Using the towel decompression, for example, the bed decompression, for example, they can be helpful ways of us to just take a bit of strain off this back, even if we are well into the recovery process. Harry said L4-5 pain down. It's migrated from the calf to the knee and the ankle. Is the disc getting worse? It may not necessarily be the disc, it may just be that the symptoms are getting worse. You've created aggravation to the disc, irritation, and it's not a material change in the severity of the actual herniation that is there, but there's more inflammation around there, and the inflammation is what is irritating the nerve. For most of you guys, when you have the disc bulges, you find, oh, it's indenting the thecal sac, or it's contacting the nerve, but most of the time it's not even doing that, it's just a disc bulge. And then they scratch their heads and go, well, I don't know why you've got the sciatica there. But you do, because most of the symptoms are going to be, beyond that initial injury, are going to be the inflammation filling these little holes. And so if you've aggravated and flared up in a minor way, you can still get inflammation around this space, and that can still irritate those nerves. And so again, hopefully you guys that have been with us for the duration of this live session are seeing that lots of you guys are saying L4-5, L5-S1, different symptoms, right? There are lots of different symptoms and experiences, and they vary hugely from one person to the other. But you guys all have that common origin of a back injury, and most of you, it is predominantly focused at L4-5, this one here, and L5-S1. Green, 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 orange, right? The last part of the lumbar spine. Part of that is to do with the sitting that we do every day. Perhaps, probably, likely, And so understand it, as much as we feel like our stuff is so different and unique to us, we realize that actually we've all got the same sort of problems. We just have slightly different symptoms and slightly different nuance. And if we focus on rebuilding health into the lower back, we find that with all these different conditions that people have, the different specific symptoms that they have, they all move towards getting better because they are building health back into the lumbar spine through this rehabilitation type stuff. And guys, just a reminder, if you need more help, we're coming up to the hour now, and we'll be signing off in a sec because we've got the live workouts, the additional workouts. For those of you that are on that are part of the membership, the new additional workouts library is going live later this afternoon. So we've got to get on and do that. So keep an eye out for that. There will be an email going out alongside that. And if you're not already a member of the program, check out the link up in the profile page. I'll paste it in the chat one more time on YouTube. Like if you've been struggling with lower back pain, with sciatica, with injuries to the lower lumbar spine, and you've tried lots of different things, just check out the link in the profile page. There's a video there. Just watch the video first, like 2 or 3 minutes long. It explains a bit more about the program. And if it looks like it's something that's more robust than the sheet of exercises you got given before, or the one-off physio appointment that you've had before, then check it out. It's about you working with us to develop the power and the autonomy to fix this yourself. No one can fix your back, but you can work with people to help you fix your own back. And build habits and practices that help for the long term. Guys, I think I'll finish it there. Just trying to see if there's any other good ones I can roll in. Yeah, exercises and stretches for a bulging disc and spinal stenosis seem to conflict one another. Ryan poses a very good question. Understand, you don't get a bulging disc without spinal stenosis. So the reason they conflict each other is because people are looking at them as different problems. Spinal stenosis simply means that you have a narrowing of a hole. There are 3. 1, 2, 3, fundamentally. A disc bulge, if it goes back to the side a little bit, is going to interfere with this hole. If it goes straight back, it's going to interfere with this hole. And if it's broad-based or going across both sides, it's going to interfere with maybe all 3. It's almost par for the course. Like saying I have a disc bulge, you're going to have stenosis to some degree. Now, whether that's significant or not is another case of fact, and is another point. But it doesn't really matter. Once you know you've got a disc injury, that's all you needed to know. Obviously, in the absence of emergency symptoms, which I should just have like a little auto respond to say that, right? But in the absence of emergency symptoms, if you've got a disc bulge, you've got a degree of stenosis. The symptoms, you know what the problem is. You've got an injury to L5-S1 or L4-5, as the case may be. That's it. Done. Now rebuild health to that lumbar spine. Looking for specific funny stretches that fix it in 3.5 minutes while you're cooking the kettle or whatever it may be, that's just gimmicky stuff, right? There are funny positions you can get into if you know exactly where the disc is going, and you're like this to the one side, and then you like look up to the sky and then flex your little finger, like sure, you can, but that's not what we're looking to do. We're looking to fix the back, right? We're looking to help support healing process, restore resilience, restore strength back into the health of that lumbar spine. That's what we're looking to do here. If I can pass this test, that would be great. There we go. That's what we're looking to do here, guys. So hopefully that helps. I'll wrap it up there. Guys, if you need more help, link up in the profile page. I do hope it's been helpful. We're trying to do these lives more regularly, so keep an eye out. Make sure you're following if you're not already. I know a lot of you guys come from the live feed, so those of you on TikTok, please do make sure you're following so you keep an eye up on this. And if you need more help, again, I stress, go check out the link in the profile page and, check out the program. It'll help you. YouTube, 2 questions come in. I'll just quickly cover these from Raphael and Brad. Raphael said, why do front squat give more aggravation in sciatica than back squat? It might be that you're not as good at them. And I think the front squats, the load is a little bit forwards. And so that's going to potentially increase we don't recommend doing front squats fundamentally, like a bar front squat. Your goblet squat, but I just wouldn't, that would be my hypothesis, would be that you're holding the bar in front of you a little bit more, perhaps, rather than having it at the back. So that might magnify the load a little bit. It might also be technical issues. So a number of different things it could be, Raphael. Brad, how many times a day should I do phase 3? I'm glad you asked that question, Brad. I'm assuming you're talking about the core phase 3, and there are the 3 workouts there. 1 time a day. Brad, as you get into phase 3 and phase 4, the need for rest days or recovery days or adaptation days starts to become more present. starts to become more relevant. So make sure that you are covering that kind of strategy and educational material to make sure that you're not running the risk of doing too much. And I would strongly suggest focusing on the hip hinge and the squat workouts a little bit more than the split squat workout, just because our main goal really at this stage of the process is building spine load tolerance, and the squat and the hip hinge are going to be your, one maybe more than the other, perfectly reasonable, are going to be your main and most safe way of building that spine load tolerance. Because again, when we've got a split squat, we now have the variation of balance that needs to be accounted for, let's say. So hopefully that makes a bit of sense, Brad. Thanks for the question. Thanks for joining, guys, on YouTube. Yeah, we'll sign off here. If you need more help, let us know. Cooking the kettle, yeah, that didn't sound, yeah, that analogy was quite poor. Boiling the kettle would have been the appropriate phrase. So thanks for joining, guys, on YouTube, and yeah, we'll see you next time. Bye.